who need pain control at this moment is something like 200,000 people. Now, we have one doctor to need for people to prescribe. When we work out the number of people in Uganda at the moment who need pain control at this moment is something like 200,000 people. Now, these doctors out there have to do the gynecology, they deliver the babies, they do the cesarean sections, they do the surgery, the major surgery, and they look after the children who are very, very ill, and, you know, so they have so much to do that they could not prescribe for maybe 100 patients a week for morphine. So we had to increase the prescribers. So we put this across to the Ministry of Health, who took it to the Parliament, and they had this statute which allows midwives to prescribe pethidine for women in labour. And we asked them to change it so that people who we trained for 9 months in palliative care and in prescribing could prescribe morphine. So now we are increasing the prescribers slowly by slowly, very slowly.
Access to morphine is clearly inequitable around the world. Something like 80% of global consumption is confined to just 6 Western and rich countries. The remaining 20% is shared between 142 countries. It's a particular marked problem in Africa. The average consumption per person per year across the African region is 18 times lower than the world average.
Afsa, she's a 39-year-old lady. She was married and she separated with her husband. She has 5 children. Since she fell sick, they have never come to see her. I think Afsa wants to see her children and her children want to see the mother, but the father has refused to let the children come to visit her. You see, she's really very sick, but she's hanging on. Maybe she really wants to see her children. Sorry.
Hi, Mama. I never went to Vienna.
No, she could be having a headache and I think she has malaria and she said, well, they might be having malaria as well because they sleep near the river and the mosquitoes bite them. And I was asking about the net, the mosquito net, and she's like, I have feared to sleep in a mosquito net. So that's why we had reached trying to find out why she fears the mosquito net. Fear is a problem of fire because in the process of the night, people sleeping, waking up, and put on a matchbox and it catches them. And they all get burned. It's also another worry.
In a busy western suburb of Kampala, Mulago Hospital has a cancer treatment centre. Burkitt's lymphoma is a curable form of cancer that doctors often see.
Burkitt's lymphoma is extremely common in Uganda and actually in a belt across Africa, and so much so that Burkitt, who actually described it first in Uganda, thought that it was related to the mosquito or to malaria or the Epstein-Barr virus, and we've never actually got to the bottom of it, what it is really related to. But it's a tumour of the lymphatic cells, and many of the children present with a huge growth on one side of their face.
Hospice team member Dr. Charles visits the centre 3 times a week. The hospice provides not just pain control, but also pays for the first course of chemotherapy in an effort to cure these children.
Okay. The mother is telling me that he's now feeling a lot of pain. The tumor was a bit small, but now it is increasing in size. Otherwise, she has been here on the ward for the last 3 months. She has been here on the ward. Yeah. Leaving her family at home. They have these kind of deadly diseases, but affording the treatment is a problem. It's a problem. Most of our children on this ward, they come from very poor backgrounds. I should say like 95%, they are below the poverty line.
It is actually a highly curable tumour, provided they have the right chemotherapy. And a course chemotherapy over 6 months costs approximately 100 to 200 euros. But the majority of parents bringing their children to the Cancer Institute can't actually afford that much for chemotherapy. And I think it must be absolutely unimaginable to be a parent and to be told that your child has a curable tumour, but to find that they're going to die because you can't afford the medication for them.
Because like out of 10 children, you can save like 2. So it is just a matter of time. Eventually they die.
Once a small fishing village, the southeastern city of Jinja has benefited from being located on the trade routes between Kenya to the east and Uganda and Rwanda to the west. It lies beside the source of the River Nile, and locals say that it takes 4 months for one drop of water to meander the 6,695 kilometers north to Egypt and flow into the Mediterranean Sea. Outside of the city, in rural areas, people like these sugarcane farmers survive on subsistence farming and trading in local markets. The average household income is about €6 a month. Access to healthcare of any kind is difficult and mostly unaffordable. With this in mind, Hospice Jinja was founded in 2005 to meet the palliative care needs of patients with advanced cancer and HIV/AIDS.
Like the rest of other hospices in sub-Saharan Africa, we focus on cancer patients and also on the terminally ill HIV and AIDS patients. And right now, as we speak, 55% of our patients are cancer patients and the 45% are patients with HIV and AIDS.
The Jinja Hospice was started with the help of local and international fundraisers and supported by people like retired Irish doctors Frank and Patricia Hassett. The size of the area the hospice covers is vast, so they have developed a unique system of community volunteers to help identify those who are in need.
We go to the village and we talk to the village leaders and we ask them for the community to choose people who they would like to help them if they were sick. So 2 or 3 come from the village and they come to a special training course in which they learn basic nursing skills, how to care for patients in the home, how to make the bed over a patient who can only lie on the floor and things like that. So it's very practical. But they're also taught when to refer patients to us which are needed. The patients who are in severe pain, patients who they suspect have cancer or have HIV. And we will meet them once a month to see if they're having any problems and to give them continuing education. They don't get paid, but if we have a donor who will give it, we are able to give them a bicycle after 3 months. Good care.
Once identified by the volunteers, hospice staff visit those who are too ill to attend the outreach centres in the rural villages.
Mr. Sulaiman Chinabi has been on the hospice program for the last 3 years. He was diagnosed with the cancer of the breast, and since then we have been taking care of him. By the time we met him, the disease was already advanced, and the best way was to palliate his symptoms and challenges that we were going through. I'm asking him to tell us how he is today. So the bleeding is controlled from the tumor, but it produces some fluid. Number 2.
But ever since hospice started treating him, they really help us. They give him good treatment. When sometimes Mzee can be there crying, saying that I'm feeling pain, but the treatment, it's very, 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 very good. Mzee is a person who has used many treatments from other places, but hospice, it's a very good treatment which they give him. It has really helped him.
Mami Chinabi, ate obulumi bwo buli butya?
Obulumi bwene genkozesa.
So when asked about his pain, he says his pain when he takes the oral morphine is controlled, since he does it 5 times a day, and he was explaining to us how he does the 5 times. When we met him, the tumor wasn't as big as that, but as we say that the cancer is continuing to grow. But in the first case, his major problems were pain and a foul smell that he was getting from the tumor. Okuwuna kuli kutya?
Okuwuna nga wena mpigana buli kuwulira ngera bw'obaawo wano bulido singa wano oli singa enindo ogikoze.
When asked about the foul smell from the tumor, he says if it were smelling, every one of us would have been. So, but it's not there, and so it is also well controlled. We really see that actually his symptoms and the pain in general are well controlled. The family is very supportive. The community has been supportive. And everybody in the community often wonders what actually hospice is giving him, so he has been alive for all these 3 years. And they think we are using something miraculous.
Even many people, they ask, what treatment do you use Mzee to stay right now? But we tell them, just go to people of hospice. They have good work, they appreciate with people. You explain everything, she or he can listen. We don't even call them doctors, we call them family members. The way how they treat us, the way how they take us. They don't take us like people who are maybe patients. They take us like family members.
Unlike Hospice Kampala, the local government imports the morphine powder. Due to inefficient administration, the teams face running out of morphine on a regular basis. The doses are carefully rationed, which can frequently result in patients running out and suffering extreme pain for days.
One of the problems that people on the ground face is the supply line. Sometimes money is available to purchase drugs when there are no drugs. Sometimes the drugs are available and there's no money. And the consequences are very, very bad for patients who can suffer immeasurably when the drug is just not available on a given day.
Florence Nandogo is 46 and has been diagnosed with a nasopharyngeal cancer.
When she had the oral morphine that we gave her the last week, the pain was controlled and she was able to eat some food. But now, 2 days, the oral morphine ran short. She no longer has it, and so the pain is back in full swing. So we straight off give her a dose of oral morphine to help her to kill the pain straight off. No, it's okay. They are asking her about the nose bleeding, and she is reporting and saying that after we met her last week, after that time, the bleeding became very severe, and it was too much that she thought maybe she was going to die then. And thank God it's later reduced on its own. And now she's having kind of bleeding still, but like the normal that she usually experiences, a little bit just. The levels of prognosis are also determined by what other treatment options you take up. So assuming maybe she had had a radiotherapy, as she was suggested 1 year ago, maybe she would be a little bit better. So it seems she doesn't have a lot of time left.
For most of the people that the hospice cares for, radiotherapy and chemotherapy in Kampala is geographically and financially out of reach. Eventually they die, leaving family and friends behind.
After a person dies, the remaining family are bereaving and grieving the loss of their loved one, and it's really important that they receive support. And that has always been a feature of palliative care, and it's equally a feature of palliative care in Uganda. So typically after somebody dies, the team will go out and visit a few days after the funeral to offer their condolences to the family. And it's really a way of sharing their loss. And people find it very supportive. And again, I think find it really helpful that the team would take the time to come to them. I think it helps them to feel that the person who's died was very valued by the team and that they themselves are valued by the team. And they derive a lot of support from that.
This is what we call a bereavement visit. We come and share a moment with the family, and we ask how the patient was before he or she passed away. And we also bring in our condolences as hospice and the team. And so we came along with other patients, and so they can also be able to sympathize with the rest of the family.
More than 1 million people have died of AIDS in Uganda, and it is estimated that another 1 million are living with the disease. In spite of the availability of antiretroviral drugs which stabilize AIDS patients, more than 60,000 Ugandans still die from the AIDS virus every year.
In 1993, 30% of the population here were HIV positive, which meant in those days very few people lived more than 7 years after they were diagnosed. Many died within the first year, and they died of intercurrent infections which were very painful, such as cryptococcal meningitis, which gave them severe headache.
It's a huge problem because it predominantly affects young and middle-aged adults, which means if they become too unwell to work, it has huge implications for all of their families. At those ages, people are typically parents, and there's a high birth rate, so family size is big. And if people become too physically debilitated, which they often do with HIV/AIDS, it means there's no income coming into the house.
AIDS was a huge problem, and Museveni was a very astute politician, and he looked at the problem and he said, we can't manage this. So he turned to the outside world and asked for help. And that's why Uganda is probably much farther along than many, many African countries, because they recognized AIDS, they said they had AIDS from the very beginning, and they did something about it.
In those days, there was no antiretroviral drugs. These are the drugs which allow patients to live a life, and many people nowadays on antiretrovirals would not die of AIDS at all. They'll die of something else. So it's no longer a life-threatening disease, as long as you can get a permanent supply. But for the rich, that's permanent. For the poor, they may get it and then it may stop, and that's a difficulty too.
Margaret was diagnosed with AIDS 4 years ago. When they found her, she was debilitated, emaciated and bedbound, with multiple bed sores and her joints frozen, unable to move.
What is a problem? What's the problem?
Problem in magulu.
The pain in magulu.
How does she describe it, Charlotte?
She said it feels like something deep-seated. It's not throbbing, it's not pricking.
Okay. Is this pain there all the time, or just when you lie on that side?
All that time.
All the time. Even now there's pain.
Margaret has severe bed sores on both hips. They have dramatically improved since the hospice first started treating her.
These are therapeutic marks. Sometimes people use traditional medicine they apply topically to near where there is maybe the affected area or the affected part of the body.
Is it painful when you move like this for us? The other one, the skin is closed over, but there's still an open area here. But it is improving, you know. I think it was very wide.
Yeah, it was.
Yeah.
It really was very wide.
Sorry?
Yeah, she does it on bed.
But it was helping.
Pain and discomfort from her illness are not the only challenges Margaret faces. When she first fell ill, her family isolated her in a room.
And she wasn't happy. She was like, no, why should they use gloves? She was touching my hand, could I infect them? And it could hurt her. She could not even eat food. Many times she would refuse to eat food because even the food they'll bring with the gloves. Even lifting her, they were touching her, cleaning her without a discharge or what, they would use gloves. And she wasn't happy. So every time she would be too emotional about it. Even to express this to the medical team when they come here, it would be hard for her. She would say, oh my God, what can I do? What should I say? And you find that now we're dealing with social pain, not physical pain. And we had to, of course, do family meetings, part of our care, that we have to meet the family separately. We tell them how the patient is feeling, and we work together and see how we can actually help her. Being HIV, and she could not walk out of the home to meet the services of HIV. So she thought she had lost hope of her. So like, now hospice come in the home and you make me sit, and it's really great because it means that there are people can survive. You can live.
Gloria is HIV positive, and she has been attending the clinic for 3 years. She's now 20, but due to her illness, she lost her sight.
I woke up one morning when everything had turned black. I stopped going to school and I lost contact with my friends. I felt like the world had come to an end.
Gloria's sister, Mary Ann, is her full-time carer. Their mother has left, and their father wants them both out of the house. Mary Ann was forced to give up her studies to care for Gloria.
So do you regret to have stayed for Gloria's case to take care of her?
I don't, but then there is this feeling, at one point you're like trying to talk sense into this person. There comes a time when they don't really consider my input. You tell her this and she shouts back at you. They tend to forget that I am a sister, older than any of them.
We always tell you that we care for the family and the patient. This is a home visit, and we always want, these are things you cannot sometimes air out in hospice. So Gloria, do you appreciate what your sister has?
Yes, very much. When we need another hand, for instance, when there are chores to be done, we need another hand. So you can like ask for her help. And and she's like very stubborn. Then that is when I also say something.
Gloria, what do you do here at home? When you are very comfortable, no pain, no what? What? Tell me.
I can sweep that.
Sorry, Maureen. Sorry. No. Sorry,
okay.
Gloria, what do you do here?
I can sweep the garage.
Can you make the room neat?
Yes.
Can you cook? Why?
I'm afraid of fire.
You're afraid of fire. So you think you can fall into fire?
Usually we use a stove. I cannot light it because I cannot be able to see the words.
Dr. Anne Merriman has established a model of hospice care now being implemented in countries across Africa.
And it's a huge achievement because as well as setting up services that provide direct palliative care and setting up high quality services that are affordable, An education system has been set up that has trained over 17,000 healthcare professionals since the hospice started in the 1990s.
This new education centre provides training to healthcare workers from Cameroon, Malawi, Sierra Leone and Sudan.
Now, all the doctors who qualified since 1994, they know what we're talking about. But we also started teaching in the nursing schools, training courses for health professionals, for traditional healers, for spiritual advisors, and we see the future of palliative care as being carried forward by those we train, not by our own service.
Uganda has demonstrated superbly that you can overcome these problems, that you can prescribe morphine, you can make it available to those who need it without it being stolen, without it being diverted into the wrong hands. It provides reassurance that this can be done in countries with very small resources otherwise.
Hospice Africa Uganda is now a proven model for palliative care that can work across much of Africa. However, in Uganda, there are still many without sufficient access to health care. After recovering from leprosy, Josephine Namaranya now has cancer in her feet. Her 6 children died of AIDS, and she now cares for her grandchildren.
The children from school whom we met out there, they are her grandchildren. They live with her in this house. Yeah, this is a very big problem in her because these are very young children now whom she has. She used to get her drugs from Mbara Regional Referral Hospital. That's where she got her drugs. Except now when she developed this, of course she couldn't go for further treatment. They said they don't have drugs for cancer. Because all patients who have cancer this end, they are supposed to go to Mulago. Mulago is the only place where you get chemotherapy, you get radiotherapy. So that's why we have so many patients here who they present when the disease has developed so much. It's because they keep going and they tell them you go to Mulago and they cannot go to Mulago. Either they don't have money, they fear they're going to the Mulago, and they just stay here. You see, sometimes people who live like here, they wouldn't know even the town in Imbarara. So now if you tell them you go to Kampala, it is a total dilemma. As much as they don't have the money, even going there, no place to live in, they don't know anybody there, they just don't feel like going there. And remember, at that time of the stage of cancer, when it hasn't developed, it's not even painful, so they don't see any reason why they should go there. Just telling somebody, you go to Mulago, sometimes they feel like now we are just trying to abandon them because we can't do much. You're supposed to go to Mulago. If you don't go, that's your fault. But it's not their fault.
The World Health Organization says that chemotherapy and radiotherapy won't be available in Africa for generations.
There is hope. One of the really exciting things that's happening at the moment is the idea that we can start to think about freedom from pain and access to pain medication as a fundamental human right. A number of lawyers, philosophers, activists of various kinds are working towards building up a case for the recognition that freedom from pain and access to pain medication is a human right. This is a much more powerful argument than we've ever had before, and it's getting listened to in places where palliative care was previously ignored.